On the canine, I would put a 5 millimeter long vertical attachment. And for the same reason, I would do exactly the same also on the right lower canine to ensure the best possible angulation control of the canine. That's the first thing. And the second thing is, if I implement more intrusion, overcorrection intrusion on front teeth, then I can, or I could, implement more expansion on the upper arch, because in fact, what I'm a little bit, it's a little bit dangerous to say that we are in fact further retracting because of the expansion. We are further retracting already retracted front teeth. And we have on the lower arch, we have no extraction. So we do a lot of IPR to compensate, of course, this. But we see here that we have as a result on this clean check a so-called perfect result. And you see here definitely contacts on the front teeth. And whenever we have contacts on the front teeth on the clean check, most of the times we have posterior open bite clinically. So this would be this is dangerous from this point of view. It is very dangerous. And this is a treatment plan decision of you to see how much you will expand on the upper arch to avoid this tendency, because you also have here these power ridges. Although you may get some torque control, you clearly see here on the clean check that we have a perfect animation result. And the perfect animation result does not mean that we have a perfect clinical result. Most of the times when we have these perfect contacts on the anterior teeth, clinically, we have anterior interferences that create open bites from the lateral view. And this is the reason why you absolutely correct provided this excessive IPR. It's exactly the way I do it also on my patient on those cases. And the only thing maybe I would consider to change is the amount of correction of lower intrusion of front teeth. Because of this, to avoid any anterior interference and the creation of any posterior open bite during treatment or after the first aligner set. And this is the reason why it is not a bad idea to implement as passive aligners. I don't know, you will discuss this with a patient, but it is not a bad idea to provide lingual palatal cutout on the second molar or on the first molar on the palatal side, and to implement and make a cutout. That would mean that you have to change the attachment, of course, on the first bicuspid, to implement class 3 elastics to control this, because you clearly see we have here good contacts. These contacts are getting even better, or from the aligner point of view, worse. So I would suggest to implement these class 3 elastics either from the beginning of the treatment, or at least on a set of passive aligners at the end of treatment to control this issue. This is the first thing I want to mention. And the second thing I want to mention is this. If you consider this case, that fixed appliance case, and the patient will ask you, how long will it take? I don't know, 20 weeks, because if we have a 1 week of aligner change, we have here a 20-week treatment to treat all these issues. And for me, this is way too short. This is way too fast. So it is not a bad idea either to slow down the velocity, or that would be the first thing, or like I said, parallel, slowing down the velocity and implementing also class 3 elastics to control the anterior interferences tendency that will be created. And this would mean that from 20 aligners, we will go to maybe 30 or 35 aligners, slowing down the velocity and asking the patient, whenever we are checking the patient on the in-office appointments, to see, is there a posterior open bite? Yes or no? And if we see such a tendency, then we tell to the patient, please wear your class 3 elastics at night or at the daytime, or when you are at home and at night. You will see that like on your fixed appliance cases. So these are issues that I wanted to mention, and I'm now, of course, open to questions. The second thing I want to mention is you have to maybe see if you provide this rotation, in fact, rotation correction of the third molars. In my cases, I tend to, at least for the first aligner set, to set the third molars as unmovable, to have a reference, a better reference what is going on. And this would be also, in my opinion, something that would make also sense. And the other issue for me, the most difficult and the most crucial part, is to close this space, this 1.3 space. I think that you need to close the space and to keep the angulation, because you don't want to tip the teeth. You need an attachment, either a vertical attachment, a long attachment, like I told you on the lower arch, also on the canine, or a horizontal bevel to occlusal on the distal surface of the canine, and a similar on the mesial surface of the second bicuspid, because this rotation attachment is not appropriate to close parallel and actually on the mandatory these spaces. And this space will have the tendency to reopen, especially when we have anterior interferences. So these are aspects and factors you have to consider on your modification of this ClinCheck. And now I'm open for questions.